Welcome again to the Friends of NPACE podcast. I apologize. That's what we're recording now. I'm sure Allison's laughing in the background because this is always entertaining. I'm Terry Schmidt. I'm an NPACE Executive Director, and I am a practicing family nurse practitioner. I've practiced a long time. I won't even tell you how much, but I'm so excited to be here today with our guest. She is one of my favorite speakers and favorite humans just to talk to. She's such a wealth of knowledge, particularly about what we're going to talk about today, vaginitis and STIs. And I definitely am itching to know more, as the title refers to. So Allison, you're a family nurse practitioner with a BA in sociology with honors from Boston College. You have your master's in nursing from Yale University, and you turned in your dissertation this week for your PhD. You have your defense coming up, but your research is focused on the connection between genital hair modification practices and associated risk of acquiring sexually transmitted infections, which we're going to talk a little bit about today. You're also a full-time clinical instructor at the Boston College Cannell School of Nursing, as well as faculty at the Sylvie Rattel STD HIV Prevention Center of New England, and you have a clinical practice as well at the South Boston Community Health Center. And you live in Cambridge with your husband and daughter and your French bulldog Jarvis. We'll talk pets later. Did I catch everything? Did we get it all?
Oh my goodness, you are amazing. Yes, Terry, you did. Hi, thanks for having me. Hi, everybody. It's really lovely to be here from freezing Cambridge, Massachusetts.
It's so cold here. That's a whole nother discussion. I don't know how anyone lives north of Orlando, but there you go.
Shouldn't
all right.
happen. Shouldn't.
No, but we can't all live in the south of Florida. So I'll start here. So we're going to talk about vaginitis and STIs. And when I originally said, hey, which should we talk about, vaginitis or STIs? You said we really can't talk about one without the other, right?
We really can't. We really shouldn't be at this point. Yeah, they go hand in hand. And since the rates of both are just skyrocketing, actually for vaginitis, right? We've had this like nice plateau for about, I don't know, 40 years that hasn't changed. But as we saw just 2 weeks ago when the CDC released the 2022 STI surveillance data, we got some problems, right? These STI rates are just going in the wrong direction and going there quickly.
All right. No, this is good. This is a good teaser. You're good at this. So I want to start. We have to give CE credit, we have to have post-test questions. So audience, pay attention. We're going to ask these first. I'm going to ask these of Allison, and you're going to tell me the answer. Deanna's going to write them down. And then I think we should head the discussion that way based on what you just said about the STD rates that the CDC just posted. So,
yeah, absolutely.
All right. First question, true or false? Bacterial vaginosis clinical guidelines have not been updated in nearly 50 years.
That unfortunately is true. We have not had any major changes to the treatment of vaginitis, recommendations, new research, new products for almost 50 years. And we know that metronidazole fails us up to 50% of the time in some patients, populations, particularly those with recurrent BV. So this is a big deal. And really, I think one of the reasons why we've seen, as I mentioned before, this plateau of vaginitis that globally has not budged from the 30% mark for a real long time. And if you can imagine that 30%, right? 1 in 3 women is walking around, and people with vaginas is walking around with some form of vaginitis, and the majority of that is BV. So thinking about kind of why that is and what we need to do in order to reduce these rates, it's likely going to also reduce our STI rates.
Oh, yeah. We'll talk about that in a second. Oh, gosh, there's so many exciting things to talk about. Okay. Second question, true or false? A woman is more likely to have BV than a yeast infection.
Yeah, by a lot. And I think the reason why I bring this up in a room of very smart clinicians who probably already have seen this and know this kind of like the back of their hand is because for our patients, this is not common knowledge. I think over the course, of your and my career, we've at least gotten more familiar with the BV as a concept. I think there are more patients who come in and say, I have heard of this before, or I have even had this before, but still sort of out in the world, a yeast infection is the most commonly thought cause of vaginitis.
Right.
And we have our over-the-counter products, right, that would help support sort of, oh, I'm a little uncomfortable tonight when I run to the supermarket and get something to fix that. But we're seeing the reasons that that's a bad thing. And one of them is some pretty significant fluconazole resistance that we're seeing starting in the country. And so we want to try to debunk that myth, right? That yeast is the most common vaginitis for our patients.
Oh, thank you. All right, last question on the post-test questions. True or false? Clinicians are missing opportunities to screen for syphilis, herpes, and other STIs in primary care encounters.
Yeah, really, and I will beat this drum, and I know how busy we are. I was a full-time primary care provider for almost 15 years prior to going into teaching, and I totally get it. It is, there is test and screening fatigue amongst us, right? From mental health to bone health to, right, all of the things that we are meant to think about when we're taking care of our patients. But sexual health, right, is just an important aspect of health as any other. And so when we are missing opportunities to have easy conversations about sexual risk, sexual practices, we're missing these opportunities both for education, but also to help part of our, help reduce these practices, or reduce these infections, the same way that we're all committed to reducing cholesterol, right? And so I think just ensuring that we give import to sexual health for ourselves. Sometimes those conversations feel a little tricky to start, right? The more we do it, the more our patients understand that we see this as part of their overall health. And things like syphilis, which are totally preventable, right? And has increased 500% in the last 24 months, right? Is something that we got to get a handle on. It's our responsibility.
Yeah, the syphilis scares me a little bit, not going to lie, especially with the bicillin shortage. So
especially with the bicillin shortage, Terry, you and I have talked about that. It's one of those things that kind of makes you go, it makes you stay up at night, at least for me. I don't know how many other people are losing sleep about syphilis. Maybe you and me are.
No, and for females, the fact that I might not see a canker, it's completely painless. I don't know, I'm walking around with this until I have a later stage, whenever that decides to erupt in a full body rash or other issues.
Exactly. Right. And has ratcheted up your illness. Right. I 100% agree, which is why sort of the idea of screening, just getting it a part of your regular practice, throwing in that treponemal test or that RPR into the person's regular labs, right? You're going to get their cholesterol. You haven't gotten a syphilis check recently, add it in, right? Syphilis and HIV are both easy tests to get at this point. They are almost always covered by both public and private insurance, particularly if providers can document that there's sexual activity where these STIs might even be a remote possibility. You can screen annually. And for sure, any of us who take care of pregnant people have to remember to add that syphilis panel into your routine prenatal care, which has been recommended and has not changed for years and years and years, Terry, right? But we had such low rates of syphilis that I think there are some places and some people who reasonably got out of the habit of checking for it because it was just never around. And we have to change that thinking now that we know it's around everywhere again.
It is everywhere again. So I'm going to circle back to the beginning. How did you get interested in vaginitis and STIs, Miss Alison?
Thank you for asking me. It's a very odd story.
Oh, I can't wait to hear. That's why we're here. Go for it.
No, it really is all derived from practice, Terry. I came out as a fresh puppy of 26 into South Boston. I've actually only had this one clinical position. They've been so good to me. And I've had such a great experience working there and in community health that I've never left, which is great. So at the brand spanking age of 26 and starting my practice, one of the things that was interesting about that organization was they had no family nurse practitioners. I was the first family nurse practitioner that they had hired and was the first provider to sort of take patients across that Rubicon from the third floor, which is pediatrics, to the second floor, which was adult medicine, a common place where we lost patients, right, for a couple of years, young, healthy, late adolescence, early 20s, weren't needing to come in all that often. But sort of being able to bridge that gap, I started taking care a lot disproportionately of young women. That's just who was showing up on my panel in Southie. And if you ever take care of any population of women or people with vaginas, you see vaginitis. You just do. And I know that you know that, right? It is one of the most common things that comes into the office. And I'll be honest, I'm not sure my education prepared me fully of what that meant and what was the pathology there and what, what should I be thinking about, particularly for people who came back with repeated infections? What was my prevention message? How can I get this from not happening? So from a young place in my career, I just got interested in the microbiology. I got interested in the treatment. I got interested in the sexual and sort of cultural practices that predispose people for getting BV and vaginitis. And we can talk about this. I, of course, could talk about it ad nauseum because it's my own personal research, but hygiene practices, right? It's not just sexual practices that can cause vaginitis. And so this sort of love and interest coincided with one of the more unfortunate aspects of my early practice, which is South Boston at that point in the mid-2000s, was in the midst of a terrible opioid crisis. And many of my patients were living with active addiction at the time that I was taking care of them. And as such, and we know that this is this substance use disorder does often come with the need to perform transactional sex, right? And so my patients were, for the need to do that, were coming in with STIs, Terry, that I didn't know what I was dealing with, right? And so I recognized a space where I needed to go get some more information. And that's when I went and found the Sylvia Rattel organization. And like you all, they offer amazing continuing ed, but very specialized in the area of STIs. And similarly there, fell in love right after taking some CE and very boldly, which was not like me and still isn't, sort of knocked on their door and said, I'm here. Do you need anybody to do anything for you? Because I think your organization is great. And got myself hired in 2008. So I've been there for that long. And those two things, continuing to practice, being with the Rattel faculty who are all, infectious disease experts, and then now going into academics has led me down this very strange path, especially to talk about at dinner parties where I am now firmly enmeshed in vaginitis research. That's how I got here.
If anyone sees you in real life after this, they're just going to stop and ask you questions about this in person. Do you get that? Do people stop you places and be like, hey, I have this patient.
Part of any day if it happens. I feel so warm and happy that I'm connected. And yes, so very oddly, and in strange places like the aisle of the CVS right next to clinic, I have had some very interesting conversations. They don't bother me, so ask away.
I love that. Ask away. You just said something in your story that I want to circle back to because it's going to get to your research. And what I want to ask about female grooming practices. I'm not going to mention any companies, but we are in an age of, I know in my social media, I'm bombarded with these advertisements for things that I must have, So let's talk a little bit about how that's playing into vaginitis.
Absolutely. So, and that I really do want to make sure that I keep this brief. I think the first thing I want to say, Terry, is that your point is so well taken. I also am bombarded with advertisements, TikToks, mostly either for products that you said that I'm intended to be using, and we'll real focus down sort of in the genital area, or by other people, often other women, who are espousing the amazingness of X, Y, or Z procedure or product, that has made them the most wonderful and oftentimes sexually free being that they've ever been before, But the underlying message for all of this is that the female genitalium specifically requires work, It requires work to exist in society as an appropriate place on the human body. And that's something that we have all, and I don't want this to come across as a should, that somehow we've been, unintelligent, and that people who sort of have for their lives, which I know I have, been thought of the female genitalia as a different area, particularly not only from the opposite anatomy, but from the rest of my own body that requires special tending, when we understand the power of that message and how long it's been in our culture. And if we look back to trace, which was so interesting during my dissertation work, to find out where this really came from, this was a hard sell to women right after the world wars. So as you recall, World War II, we're Rosie the Riveter. We have left the domestic sphere to take the place of our friends and family members who are deployed right over in Europe.
Yes.
But now all the soldiers are coming back. Men have predominantly inhabited those social and occupational spaces. And so women were essentially pushed back into the domestic sphere. And it's right around this time, it's really interesting that the market was flooded with advertisements about specific genital hygiene practices and products that women should start to use in order, very specifically in this cultural context, to be appropriate for their husbands. And that the natural state of the female body was totally inappropriate, right? And was going to make you a poor partner and could even potentially influence your reproductive capabilities. So women all of a sudden across popular magazines, television, were sold products like things from Lysol that said, this is your duty. You need to use this in your vulva. And interestingly, lots of intravaginal products, lots of douching, lots of water baths were suddenly put into the market as these necessary items to use. And the messages worked, right? A lot of women started using these products regularly in their vulvas and inside their vaginas. And we have now had almost 80 years of research looking at what happens when we use products both intravaginally and on our vulva. And as it turns out, consistently for about all of those years, it's shown that it increases the rates of vaginitis, which makes a lot of sense biologically, right? The microbiome of the vagina has evolutionarily become perfect at maintaining itself. Right? It doesn't need our help in order to be clean and to be normal. So when we disrupt that microbiome, both by intravaginal products and vulvar products that weave their way, right, as they do into the vagina on accident, we are setting ourselves up for these sorts of infections like BV. And as you can imagine, the repeated use of these products keeps the rates going. It's a self-fulfilling process, right? That's circular. We're on a hamster wheel. And so the other piece of this research, which is really interesting, is it's shown that having vaginitis is in itself an independent risk factor for acquiring other STIs.
That was my next question. It's like you can read my mind.
I just love this stuff, Terry.
I know.
So, right, this is how we can sort of start to tie together the health outcomes that are associated, right, with our genital hygiene products and use and practices. And thinking about how we as nurses, right, how are we going to assess for this? How are we going to talk to our patients about it? How do we promote behavior change around something that is so deeply embedded in our culture, right? So as much to be associated with our gender identity, right? Women's bodies look like this. Women's bodies smell like this. This is a message that we have all, right, been influenced by. One of the things I hope has some staying power is trying to start to make this connection into the world of STIs, which hasn't been done before.
Okay. I'm going to take a drink of water while I ponder that, while the audience ponders that. If you guys have your beverage, just feel free to. All right. So then my next question as a clinician is, if I have a patient who has repeated vaginitis symptoms, right? And sometimes they don't even come to me and say, I'm itching. They just say, I can smell this. Right. And they don't like that. But if they have repeated vaginitis and I'm not screening for an STI, am I failing them somehow? Should that be an automatic trigger for me to go, we should maybe.
Great question, Terry. I think the short answer is at least at the beginning. If this is a patient perhaps that you're seeing for the first time, you're getting that chart review, right? And you notice that we've had these repeated episodes of vaginitis with no recent STI screen, or the person comes into your urgent care right? You don't have those records that tell you when the last time they were in. It's reasonable to ask, right, the sexual activity questions because it is a vaginitis. So if you get positive sexual activity, it seems very reasonable to me that the next question is, when was the last time you were screened for STIs, right? Now, based on risk, you absolutely can tailor that panel of diagnostics to the patient sitting in front of you. And if their person is very low risk and has had a STI screen within the last 6 to 12 months, maybe you're going to defer that for today, right? I think annually for the lowest risk patients is certainly reasonable if nothing's changed in their partnership, right? And this is not a patient who's presenting in acute, right, like with an acute abdomen or anything that's clinically that concerning. So the short answer is sure. For the majority of people, I think it's a reasonable thing to make the mental leap from vaginitis to STI screening. But then, as we do, use your good clinical judgment to figure out who, when, how often, right? When the last time was. But yes,
Okay.
short answer.
All right. No, that was good. I'm going to carry that back into practice with me. In that same thread, when you're testing for STIs or even seeing people in the office, what kind of trends are you seeing? I'm sure this will bleed into what the CDC just published and what we know now about syphilis, but what are you seeing in clinical practice?
So, I will say, I think my practice ends up looking very similar to the statistics. Lots of chlamydia, right? Lots of asymptomatic chlamydia, lots of young person chlamydia, right? This is something that's just, we know. Far fewer cases of gonorrhea, but not none, right? And I think, interestingly, what has not been showing up so often for me anymore is the twofer, right? We have these bundles of gonorrhea and chlamydia tests that always come together. If you notice, a urine test is for both. You almost can't separate them in most places. And that was because for a long time, and still in certain populations, those that have chlamydia are more likely to have gonorrhea at the same time. So why not get a twofer? But they can be decoupled, right? And if you're going to see one more than the other, you're going to see exponentially more chlamydia. So trust your tests. Use the ones you have. It's great to screen for them together. On the vein of herpes, I always see a lot of herpes, right? Because I'm got my herpes magnifying glass out all the time. Herpes shows up in a lot of different forms, and I think having it on the brain is a good idea, particularly for those people, and we'll just refocus on our population whose vaginitis isn't making sense to you, right? So you're seeing them, and perhaps they have a record of not really testing positive for vaginitis. They keep coming in with symptoms, itch, irritation, stinging, maybe some odor, right? And you're just not getting a classic picture of BV, yeast, or trichomoniasis. Think about herpes. Is this a triggered timing, right? Is this something that tends to come back up with stress, with finals, with vacation? Is there one area that's more irritated or itchy than another, right? Sort of a focal presentation of discomfort. And then I think, again, to your good point, if you're suspicious, roll a swab around in there. You don't necessarily have to have an active lesion, right, in order to justify doing a herpes swab. And if that puppy comes back positive, that's herpes, right? Regardless of what else might be going on, that person has active genital herpes. So we know that a genital herpes in the form of HSV2 tops out at about 11% of the population over time. Right? So not that many people have HSV2, but man, has HSV1 been doing tricky things over the last 20 years. And we're seeing tons of HSV1 show up in the genitals where we hadn't before. So that is an awesome thing to do, right, in clinical practice, is just to keep herpes on the brain, because we know that up to 40% of all people are seropositive for HSV1, right? By the time they hit their 4th decade of life, there's a ton of HSV out there, not all symptomatic, right? Not all clinically significant, but we're missing a whole bunch of herpes still. So keep your eyes peeled for it. And then, yes, I am getting syphilis, right? It's, again, not often and not common, but I am seeing it. Gratefully, I have not taken care of any pregnant patients with syphilis, right? Because our biggest concern there is congenital syphilis. But the trends that I see in my practice are pretty similar, but I will tell you, vaginitis symptoms and concerns dwarf those. Dwarf them by exponential amounts, right? Particularly now that I'm in urgent care, I would say that if, out of a 20 or 30 patient day, I will routinely see 5 to 8 female patients with vaginitis complaints in a single day.
Wow.
Yep,
That's
very, very common.
so many uncomfortable women out there.
So many uncomfortable vaginas. Yes.
They just live with it. Yeah. All right. So what are we missing as clinicians? Like, what should we be focused on? The one or two things that could help in screening, vaginitis discussions, whatever.
Sure. So a couple of points that will come up. I want to be clear, Terry, for everybody who's listening, that this really is sort of newer research. There are no clinical guidelines to talk to your patients about their genital hygiene practices when taking either a health or a sexual history. I want to be quite clear about that. It's not as if providers are missing something that has been out there in the world as a recommendation. Now, surely if I can have my way, there would be, because I think we can there's enough evidence to support that at minimum, we should be asking as a part of a general health history, your sexual practices and your hygiene practices, because then what we can start to put together, particularly for those patients that have these repeated vaginal infections, is some language around what we know. We know that intravaginal cleansing, even with just water, raises the risk of BV. So if you are someone who has a lot of BV, could we consider not doing that practice anymore, right? And asking our patients to think about that. The evidence on vulvar product use is really new. We're talking about the first study that came out about this in Canada, which was a broad-based population study, was in 2018. So it's really brand new to show the association between commercial genital hygiene products and increased rates of both BV yeast and other STIs in women. So the idea that we should all be counseling patients differently about this is probably not something that I can back up with evidence. However, I would still say that it's a conversation I often have with my patients. What do you use? I'm hearing that you use a special product, 2 or 3 products, a shaving cream, right? All of these things combined may be contributing to your recurrent vaginitis. Could we switch, right? Could we decrease? What will you feel comfortable doing in an effort, right? Not as a, you must because I am the provider and you should, but in an effort for you to get this problem to be better.
So let's clarify what those products are before we move on from here. Soaps, vaginal deodorants, shaving creams, douching. What about
wipes? Wet wipes from the toilet, huge ones, sprays or powders that people use. And if they have not linked them directly yet, but there's a separate set of evidence that daily use of panty liners outside of menstruation can also cause problems, particularly if they're scented. So these are all things to consider. How much is sitting up there and touching this tissue, right, on a regular basis?
So you are steeped in the research. My other 2 questions are tampons or scented tampons or menstrual cups. Any?
Great questions. Right now, there is no data to support not any significant data that any menstrual cup is causing problems. Again, it's used typically during menstruation. Menstruation is often a time when vaginitis can kind of self-correct because the pH goes up and we're getting this flushing, right? So there are times when menstruation causes the microbiome to actually repopulate afterwards, which is awesome. Sometimes it does the opposite, to be quite honest. But because menstrual cups are very clearly not used daily for the majority of people, right? They have been so far gotten off scot-free. Scented tampons, Terry, to the best of my knowledge, this is going back a couple years since I have read the most recent literature, can be problematic. However, unscented tampons, I believe, have not been shown to increase the risk of vaginitis. What I do think, again, is important to remind people, though, is that they are intended only to be used during menstruation. I've had patients come in and say, I don't like my discharge, so I wear a tampon every day, even when I'm not menstruating, right? I want that to be absorbed. That can cause issues with vaginitis for sure, because the flow isn't enough. It's not that sort of perpetual flow of fluid, right? And so it ends up acting like a retained foreign body, and retained foreign bodies screw up our microbiome and can increase the risk of vaginitis.
That
So
makes
asking
sense.
patients all the way through, soup to nuts, you wake up, what comes in contact with your vulva and vagina until the time you go to bed? It's sort of how I phrase it in the history, and let the patient tell me what
It's
they're
like
doing.
a 24-hour diet recall.
Totally. Yeah. It's a 24-hour diet recall for your vagina. Absolutely. Who's coming over, right? Who's knocking at the door? All of that good stuff. And that largely leads, that conversation often will intertwine with sexual activity and practices, right? So I hear things like, oh, I only douche in after sex. Oh, I only shave right before sex. I only shave right before I come to see you, right? These are the sorts of things that you can start to parse out from people by getting that sort of longitudinal history.
Yeah, no, I appreciate that. Oh, you should see the audience comments. We'll have a couple of questions, but there's just so many comments too. Someone had said that they don't recommend dryer sheets and fabric softeners sometimes when people are even really, because we're talking about anything that could cause dermatitis.
Irritation. Dermatitis,
Right.
absolutely, right? I think that's a brilliant, and I'm so glad I'm so glad the audience is with us. It's so hard when I can't see anything and I'm wondering, I'm like, is this going okay? All of these things sort of make sense to us in other contexts, and we don't have any issue when somebody comes in, right, with a brand new rash after using a new detergent to say, hey, maybe switch it out. But we don't have that conversation about this very specific area, right, that actually is so much more dynamic and vibrant, right, than other areas of epidermis. And so thinking about it in that holistic way is what I love about nurses. Yes, it's your dryer sheets, your towels, your fabric softeners, right? All of that counts.
Yes. And I love that we can have those conversations with patients and they go,
Me too.
oh, wow, okay.
Me
And then
too.
I own teenage people, and I'm finding that whatever that conversation is with that young person, they tell their friends, right? And so this is how we get the word out to combat the social media messages.
Well, it's really cool. Our young groups of people, particularly our young people of color, are really resisting and have been on the forefront of resisting some of these messages about what an appropriate vulva and vagina are supposed to be. And so we've seen that those messages are starting to reach the general public about augmenting your body from its natural state. And what does that mean, both socioculturally to you, but also potentially health-wise? And I think you're right, Terry. I think this is a generation of smart, engaged people who are willing perhaps to make behavior changes faster than us old fuddy-duddies in the space of evidence, right? And messages that can get spread really quick. So I'm hopeful that these conversations are happening. I think it behooves us all to have better health, and particularly better sexual health.
Yes, which is critical to all of us.
Critical. And we know that younger people are disproportionately getting our STIs, right? That again is a statistic that hasn't changed for decades, that 50% or more of all STIs occur in people under 25. So this is where the messages have to be happening, right? So start young with this idea of what is an appropriate way to care for your body, what is in fact hygienic, what is necessary for actual healthy hygiene, as opposed to what we do because, right, those messages have come through for so long that all of us are supposed to smell like lavender somehow in every part of our body.
Well, we don't naturally smell like lavender.
And
oh my gosh.
Sparkle and glow.
All right. I could talk to you for hours like this. I am so fortunate that I have this space to talk to you and that you're willing to come and talk to us. We have a million questions. I'm going to hop to just a couple of them, and I'm going to tell everyone here, because we're going to roll this as a podcast. So for whoever's here, once you hear this, if you have colleagues, we won't probably put the podcast out, publish it until April, although we're recording everything here all day. Yes, I said that. You have access for 30 days. Once we load it, give us a week, edit videos and send them up. But for those of you who have a clinician that you know that, or a student or a mentor that needs to listen to what Alison is saying to us here, we're going to publish this and you can just send it to them. It'll be out everywhere you get podcasts. So I'll throw that out there before I want to talk about gosh, there's so many questions. Okay. All right. One of the questions, and I get this a lot, and I'm seeing it in practice, and then I'm like, I don't really know what to do with this because it's out on the internet. What are your thoughts on testing for mycoplasma and ureaplasma in the urine?
Oh, great question. I'm so glad it was asked. Okay. My thoughts are that as a organism, right, it exists. We are fairly confident by evidence that there are some pathological symptoms that can arise from having an overgrowth of mycoplasma or ureaplasma. What those are specifically is not necessarily been generally defined. And I think where we're lacking guidance is when should we be adding that test in? Should it be routine? Is it now part of a broad-based comprehensive STI panel? Or is this one of those secondary type tests where we test for the more commonly found organisms first and save this as a secondary test for people who either test completely negative or continue to have repeated symptoms? The other sort of issue with mycoplasma is it's a very slow growing organism and it's tough to eradicate. If we remember that there are low levels of mycoplasma and ureaplasma in the vagina all the time, what is that cutoff where one, it's too much and could be causing symptoms, and where is the level that we consider it eradicated, right? So the other consideration is that right now our recommendations are to use very broad spectrum antibiotics in the treatment of this organism, which leads us to a little bit of a conundrum, which is if we're not 100% sure it's causing the symptoms, and we have to use a broad-based antibiotic over a longer period of time to reduce the colonization, should we be testing for it in this way until we know more about it? And that, I think, is the real conundrum, because the tests are available. We all know they're available. People know about mycoplasma. They come in asking for mycoplasma tests, right? I'm sure that your patients are like my patients and well-versed in what's possible. So I think right now I would say that my advice is it's tricky. I would have conversations with patients about our uncertainties right now. And I personally use it as a secondary test. I say to people, I hear you. Okay. I want to make sure that the commonly known things, right? If this is a generalized BV, as opposed to a mycoplasma specific overcolonization, my treatment regimens are different, right? So I want to be doing the most appropriate thing for you here. So let me run a general vaginitis panel, a chlamydia, a gonorrhea. We'll think about some serology. If either none of that comes back positive and you continue to feel bad, we'll get that mycoplasma. But if not, and something pops positive, maybe we should treat you for that first and see what happens.
On that note, before we wrap up, because we only have a few minutes and this is so great, I want to talk a little bit about herpes testing, because I have patients coming in asking for blood test serology, and I'm like, we have that conversation.
Well, not a hard no, but no for most.
Yes. All right. So how do we test for herpes and when should we? Go.
Go. Well, the first thing I will say is that this is a complicated issue, and the CDC has a wonderful page for clinicians that answers that question exactly, Terry, in bullet form. Who should be getting serology? But the overlying message on that page is asymptomatic, healthy persons should not be screened using serology. Done. So that's a huge swatch of the population that comes into you and says, I want to be tested for everything. Asymptomatic, never had any symptoms, you do not and should not, according to the evidence in all of our major organizations, add in HSV-specific serology into that panel of testing. Now, there are groups of people who should and could get HSV testing serologically in the absence of symptoms. One of the ones I'll bring up here just shortly and let everybody read the others is dichotomous couples. So we have somebody who comes in and says, my brand new, wonderful, amazing, fantastic partner has had her genital herpes and I have not. We want to know what to do about this. So what we do there is we test the asymptomatic partner, because here's what happens. If it comes back positive for HSV antibodies, your counseling message about what they need to do to protect their sex is different. Both of these people now already have antibodies to HSV, as opposed to this person comes back negative on serology. Then the recommendation is to potentially discuss suppression in their partner to avoid transmission into them.
Okay.
Great rates of that. So I think that's a common thing that I see come in when people say, oh, I have this risk. Now, if they've had symptoms, if they've been told they had herpes before, these are all cases where getting serology is now more appropriate. But for the general population, asymptomatic, never had symptoms, we don't add in serology because it's not a good marker of infection, not because there isn't herpes out there.
Correct. Right. So better off with a swab in patients who have symptoms or outbreak.
Yeah, you got it. And if those symptoms are atypical, just remember that's what herpes does. So a little itch, a little, oh, that's my shaving blister. I like that one. Oh, really? Shaving blister comes up same time, every time, same place? Not a shaving blister, right? So some of these things just to get your spidey sense up for herpes, and you'll find more of it.
I love it. Yes, we're all going to be testing more. All right. So Alison, thanks for talking to me. I'm going to close this out.
Thanks for having me.
I'm so glad you came, and you're going to be back later in the day. Look at the schedule, everyone. Alison's going to be back in a couple of presentations to talk about female sexual development. And I've heard that presentation. It's fantastic. So thank you.
Thank you.
Just to let everyone know, be sure to check out npace.org for information on all things NPACE. You can find us wherever you find your podcast. There is some CE credit related to this today, so be sure to do your post-test and your evaluation survey. Thank you so much for the questions. I love doing this live. We should do more podcast recordings live so we can get audience questions, but thank you so much for tuning in. This concludes our Friends of NPACE podcast. Keep an eye out on our website and social media channels if you don't already follow us there for when this will be released. And again, it'll be closer to April. So also, all of you here today for the conference, thanks for joining us live. We're going to take a 15-minute break. Something very cool happening today in the virtual world is there's fun things to do during breaks. So there's meditations. You can catch some of the podcasts. There's yoga. You just click into that session and you can run that video. We're going to take a 15-minute break, and then we will be back at 10 a.m. Eastern time with AACE. We're going to talk a little bit about diabetes therapy. So we'll see you back in 15 minutes. Thanks, everybody.